Thank you very much, Dr. Rawan, for the clear and informative session on dysuria. Your practical approach and clinical insights were truly valuable for our daily practice in primary care. We're truly honored to have you here with us today, and we sincerely hope to welcome you again, inshallah, in the future events, inshallah.
Thank you, Dr. Badal. Thank you.
Thank you very much. Now we'll move on to our next session, and I'll hand things over to my colleague, Dr. Abdallah, who will be guiding us through the upcoming presentation. The mic is yours.
Thank you, Dr. Badal. For next and last lecture, it's my pleasure to introduce Dr. Saad Al-Masab. He is our family medicine senior reg MSc Neuroscience and Psychology of Mental Health, trained in CBT and Compassionate Inquiry. He will share with us his lecture and he will talk about mental health in primary care. دكتور سعد مساء الخير the mic is for you. تفضل دكتور.
السلام عليكم، مساكم الله بالخير جميعا. يعطيكم العافية والسموحة، تأخرنا عليكم شوي. نسوي شير.
You can share the presentation, doctor.
Yeah, I know. This is gonna be a long lecture, but I'm gonna skip a few slides, which you can read later. The main aim of this lecture is to have a family medicine approach to mental health in general.
Doctor, excuse me. Can you please hide the black box of the video?
This
you
one?
Can just put a slide. Yeah,
How
the
do I
slide.
hide it?
Just you can drag it and keep it in. Drag it and put it in the side. Minimize it.
Okay, like this.
Yeah. Yes.
Perfect. Yes. Perfect. Okay, so as I said, this is a lecture. It's an approach to mental health from a primary care perspective. So us as family medicine doctors, how do we target mental health and how do we approach mental health? But to begin with, I'd like to ask, why do you think we need to talk about mental health? Why do we need to learn about mental health as family medicine doctors? Can you maybe share your thoughts in the chat? I'm not sure if I can go back to Zoom. Oh, yeah. Anybody? Why do you think we need to talk about mental health? Why is it important to talk about mental health? Daily complaints. Stigma associated with seeing a psychiatrist. صحيح دكتور حسين. High prevalence of mental health conditions. نعم دكتور علاء. So, as Dr. Ala said, there is a very high prevalence of mental health conditions in primary care compared to other sections or to other specialties. Almost more than 1/3 of the patients we see can have a diagnosable condition. And in primary care, we can provide early detection and early intervention, which is because, as you know, primary care is the first place where the patient comes to see a doctor. And we need also to appreciate that there is a shortage of mental health specialists, especially in Kuwait. And people usually go to private because it's more, let's say, there is more privacy, there is more confidentiality. That's what they think. Of course, we keep the privacy and the confidentiality. But even the good doctors, the good specialists are found more in the private sector. So there is actually a shortage of mental health specialists. And the fourth point, which I think is the most important point here, us as family doctors, we have a holistic approach. We have a biopsychosocial approach. We have a patient-centered approach. We don't see the patient
Dr. Saad, we cannot hear you. Dr. Saad?
دكتور سعد يعطيك العافية، بس إذا تشوف المايك لأن ما نسمع شيء.
Hello, Dr. Saad, can you hear us?
يعطيكم العافية جميعا، بس ما عليكم أمر، نشوف بس الموضوع مع دكتور سعد ونكمل إن شاء الله.
Sorry for the interruption. Guys, can you see me? Can you hear me?
Yes,
إيه
doctor, we
دكتور،
can see.
Okay.
تفضل دكتور.
If there is an interruption or anything again, you can guys call me again. I didn't know where I stopped, but I was talking about the difference between, let me share the screen again. I was talking about the difference between reality and textbook and how the difference can be huge actually, to a point where someone could be even misdiagnosed. Okay. Do you see the slides?
إيه دكتور، تفضل.
Okay. So it's very important to know that we're not here to pathologize emotions. Emotions are a totally normal part of our human experience. Why طبيعي إن الإنسان يشعر بالحزن، يشعر بالخوف، يشعر بالضيق. these are normal human emotions, to feel sad, to feel anxious or fearful. What's different is that in a psychiatric disorder, in an anxiety disorder, in major depression, there is something different about this sadness or this anxiety. And the difference lies in the severity of the symptoms and in the length and duration of the symptoms. For example, for depression, the symptoms have to be there for at least 2 weeks. For anxiety, they have to be there for at least 6 months. Also, what's the most important point is the effect on life and functionality. So how is this affecting the patient's life? How is it affecting their work? How is it affecting their relationships? How is it affecting their functioning in life, basically? And the DSM criteria of different mental illnesses and categorizations are very helpful for us to diagnose and to guide us through different kinds of mental health disorders. And there are many more than the ones you can see here on the slide, but I only mentioned the ones that I think are relatable to us and the ones that we need to recognize as family medicine doctors. Of course, we're not going to talk about all of these, but the common ones that we see in primary care are depression, anxiety, somatization, sleep disorders, of course, and also OCD, trauma and stress-related disorders like PTSD, for example, and also personality disorders, which we are not supposed to diagnose, but we're supposed to recognize. Okay, I have a table here which has all the different common conditions which we can see in primary care, and I divided the management into mild, moderate, severe. I'm not going to go through this because it's a lot. You can read it in your own time. The main thing is to know the DSM criteria and the management. In the exam, you might be asked about specific things, especially for depression and anxiety. It is necessary to know things like what kind of medication you would give if the patient is pregnant, or what kind of medication you would give if the patient is breastfeeding, what kind of SSRI is safe in these conditions, for example. These things are very important to know. The other thing is we need to differentiate the different conditions. So knowing the DSM criteria can be helpful in differentiating the different conditions. And a key thing in psychiatric disorders is you'll find the trick in the name. The name of the condition tells you what it is. It tells you what the condition is. So what's left is just details, basically. So I'm not going to go through these tables, but we're going to talk about a case, okay? So let's talk about Iman. Iman is a 37-year-old married woman who presented with a 3-month history of depressed mood, anhedonia, and poor sleep. She mentioned having headaches, numbness, feeling dizzy, and fainting on multiple occasions. She's also experiencing difficulties with her relationship to her husband, and she's been taking a lot of sick leaves recently and has been neglecting her side business for the past 3 months due to lack of interest. She has 2 kids, and she scored 16 in the PHQ-9 screening tool for depression. And there was no history of mania or hypomania. There were no neurological symptoms. And there is no family history of mental illness. So you want to now take a history from this patient, a psychiatric history. What else would you like to ask about? Is there anything specific that you'd like to know in order to diagnose this patient? What investigations would you like to do? What differential diagnosis do you have in mind for such a case, given that she has symptoms like depressed mood, anhedonia, poor sleep, but she also has headache, numbness, and feeling dizzy and fainting on multiple occasions. So there are also physical symptoms, not just psychological symptoms. Can you maybe write in the chat, what do you think? What else you want to ask, or what do you think the differential diagnosis could be? I wish this was more interactive in a way that people can unmute their mics and answer. Let me see if I can have a look at the chat. Doctora Aya, yes, sleep, appetite, concentration, psychosocial, suicide, yes. Perfect. So in a psychiatric history, we need to treat it as any kind of history. So it's the same thing. Patient will come with something. The patient will come to you complaining of something. So for the presenting complaint, we need to assess the onset, the Socrates, basically, onset, duration, severity, triggering factors. And we need to ask about associated symptoms. In psychiatry, these are the ones that we need to ask about. The mood, is there any sadness, low mood, irritability, anxiety? We need to ask about worry and panic attacks. Energy levels, concentration, changes in weight and appetite, a sleep disturbance, psychosomatic symptoms, and psychotic symptoms to rule out any causes of psychosis. And then also we need to ask about coping and support. Is there anybody that's helping them cope or support? Do they have any support system? Do they go to a support group, or do they have good friends that can help them cope with these problems? And the past psychiatric history is very important. So have they been diagnosed with a mental illness in the past? Do they take any psychiatric medications? This is very, very important. And when the patient tells you that they've been diagnosed with something, don't get fixated on the diagnosis. It might not be, I'm talking now about reality, about what's happening in reality. Do not get fixated in the diagnosis because it actually can be a different diagnosis. So we need to assess all over again. Medical and surgical history, of course. Family history, because certain mental illnesses have a genetic component, a very strong genetic component, like bipolar disorder and schizophrenia. Social history is very important. Having the patient's ideas, concerns, and expectations, checking the patient's relationships, whether they have kids, whether they're married, because that can be reflected in many other things. Substance use, of course, and risk assessment for suicide and self-harm. This is basic and needs to be mentioned in all psychiatric histories. And checking the patient's insight, like what does the patient think about their condition? What do they what's their insight about it? Because insight is a big thing in psychiatry, as you know. For example, someone who has psychotic symptoms, they would usually lack insight. So insight is a crucial part of a psychiatric history. There are many tools which can be used to help us screen for certain conditions, but these tools cannot diagnose. We cannot use them in diagnosis. They can help us or guide us through the history sometimes, but at the same time, do not use these to diagnose. Use them just to give you an idea of what the patient is going through. Maybe it will give you an idea of the severity of the patient's condition, but it will not give you a diagnosis, basically. Sorry, because these are not specific and not sensitive for these specific conditions. But it's helpful if you work in a mental health clinic. It's very helpful to have these tools printed, maybe. And there are many lab tests and investigations that can be very helpful to do, but NICE guidelines does not recommend doing them routinely unless there is clinical suspicion of an organic cause. So that's what NICE guidelines recommend. But in reality, we actually do all of these tests for everyone because they're accessible, but not all of them, because like we do not do the inflammatory markers or the drug screening or the imaging, but we do thyroid, we do CBC, we do the metabolic panel and the vitamins and the ferritin. But it's not recommended to be done routinely for everyone, unless you suspect, for example, that the patient may have a thyroid issue or a vitamin deficiency or anemia, for example, or an autoimmune disease in which we will check the inflammatory markers, because several autoimmune conditions can actually present with psychiatric symptoms. So let's go back to Iman. Iman's labs were normal. She was referred to the medical side for further investigation of recurrent syncope. MRI brain was done, and it was found to be normal. She was cleared by the medical side, and she was diagnosed by medicine with depression. She was advised to be started on an SSRI, and she was started on Supralex 10 milligrams, and she was then referred to the psychotherapist to start CBT. After 2 to 3 months, the patient reported improvement in depressive symptoms, but she's still facing difficulties with her husband and several other relationships. She also casually mentioned that yesterday she took 6 tablets of Supralex and directly told her husband about it. So what do you think is happening here? So she was diagnosed with depression, given Supralex 10. She slightly improved, so her symptoms slightly improved, but she's still struggling. She's still struggling with her relationships, and she tells you she feels better, but she took 6 tablets of Supralex. What's happening here, and what would you like to do? If you can share your thoughts on the chat. Victoria Zainab, attention seeking. Yes, that can be something. So in terms of attention seeking, what are we going to think about? What condition or what diagnosis would be associated with attention seeking? She may be bipolar, maybe cry for help. But usually when you start a bipolar patient on an SSRI, it's going to trigger a mania attack. Personality disorder. Yes, it could be. So any patient who comes tells you that they did a self-harming behavior or something that could be risky, it could be, you suspect it could be suicidal, for example, you need to do a suicide risk assessment. And unfortunately, there isn't any scoring system or questionnaire in which we can use to determine the severity of suicide, and nothing that's recommended by NICE guideline, or any other guidelines, by the way. But there is a comprehensive risk assessment, which is done in the consultation, in the clinical interview. And for us to actually assess the risk of suicide, we need to establish a good relationship with the patient. We need to establish rapport with the patient, a trusting relationship, a therapeutic relationship. And we need to assess the risk factors for suicide, and I'm sure you all know them. So the severity of the mental illness, previous history of self-harm or suicide, the age, it's more common in patients from 18 to 45. Gender, it's more common in male. Social situation, it's more common in single people or in socially isolated people. Access to lethal methods, for example, if they have sharp objects, if, for example, the patient is an addict, they can easily OD, for example. So we need to ask about access to lethal methods. We need to assess the current intent and planning. This is the most important part. Do they intend to do something? Do they have an intention to do something? A lot of them were going to tell you, yes, I intend to do this, this, and that. I intend to do this, this, and that. What are you planning to do? They might tell you, I'm planning to write a message or a letter to my family before I do it. So it's important to ask about planning. What are you planning to do? And you need to know that if you ask the patient about suicide, it does not increase the risk of suicide. Asking the patient about suicide is protective. So don't be afraid of mentioning suicide to the patient. It's actually protective. It does not increase the risk of suicide. There are protective factors like social support, having responsibilities in life. For example, having kids, you're going to feel like you have responsibilities towards them. So it's going to decrease the risk of suicide. Also, having faith from all different religions will also be a protective factor. So upon assessing Iman for suicide risk, the patient mentioned that she never intended to end her life. She said, I just felt like doing it. بروحها كذي والله ما أدري يعني حسيت إني بسوي هذا الشيء. But she made sure to tell her husband right away. She also mentioned that she went to the emergency department that day and she was discharged without any treatment. Upon further assessment and direct questioning, the patient mentioned feeling worried that her husband might leave her. She claims to have frantic, unstable emotions lasting for hours to days. بنفس اليوم أحس إني وايد مضايقة، بعدها بكم ساعة أحس إني وايد سعيدة وأبي أسوي كل شيء في الحياة. She mentions having certain behaviors like drinking alcohol and smoking, which she denied previously. And also she reported feelings of emptiness. What do you think that the diagnosis could be in this case? Are you going to change your mind about? دكتور حسين borderline. Yes, دكتور سعود دكتور حسين صحيح. This patient was then diagnosed with borderline personality disorder. But before I go ahead and talk about borderline, I just want to mention the strong overlap between the different psychiatric disorders in reality. And مساء لما انقطع الاتصال أنا كنت قاعد أقول سالفة ما أدري سمعتوها ولا لا، راح أقولها مرة ثانية. I have a friend who has been diagnosed with 3 different conditions by 3 different psychiatrists. So the first psychiatrist diagnosed him with OCD. The second psychiatrist diagnosed him with bipolar. And the third diagnosis by the third psychiatrist was ADHD, okay? And you can see how, in reality, psychiatry is not objective. It's very subjective. Subjective from both sides. It's subjective from the patient side, of course, because the patient is telling you subjectively what they're going through. And there isn't any objective way to exactly tell what the patient is going through exactly or what's the diagnosis is. And also, there is a subjectivity from the doctor's side, from the psychiatrist's side. So it is very important to reassess the diagnosis if the treatment fails or if you don't see enough improvement. يعني أنا أدري إذا في سايكايترست هني وسمعني أقول سالفة هذا راح يزعل، بس هذا الواقع يعني. It happened in reality. It happened where 3 very good psychiatrists, actually very skilled, and one of the best psychiatrists in Kuwait, some of the best psychiatrists in Kuwait. Anyway, so let's talk about personality disorders and what they are specifically. I'm gonna go quickly through them. I'm not gonna, because we don't have enough time. There is a difference between personality traits and a personality disorder. So personality traits أو الشخصية، شنو شخصية الإنسان. The personality traits are enduring patterns of thinking, feeling, and behaving that form a normal range of personality and does not cause significant distress or impairment. For example, some people are introverted. يعني, I have an introverted side, so I prefer to do things alone or with close family and friends. But I can also go out and be with a large group of people. That doesn't make it's not an issue with me. So there is flexibility in the personality, even though we lean towards something. So some people, for example, have less openness and more conservative, but still they can be with other people who are more open-minded and share their thoughts. Personality should be flexible, but in a personality disorder, there is an enduring and inflexible and pervasive personality. And this has to be stable and long-lasting, usually starting in adolescence or early adulthood. And it leads to significant distress and impairment. Their personality leads them to having significant distress, significant impairment. That is not explained by any other condition. So for this patient, for Iman, why we consider the diagnosis of borderline personality, because she had frantic efforts to avoid real or imagined abandonment. And it was imagined because her husband loved her. Her husband loved their kids, and he was there for her. But she had an imagined fear of a fear of imagined abandonment. And there is a pattern of unstable relationships going between extremes of idealization and devaluation. يا أحبك يا أكرهك، ما في بالنص. يا أنت أوصلك السماء يا أوصلك بالقاع. يا idealization يا devaluation. So they have something called black and white thinking or splitting. They also have an unstable self-image, an unstable sense of self. They might tell you, I feel nothing inside. I feel like I'm empty. I don't know myself. They also have impulsive behavior. And in Iman's condition, you saw that impulsively, she started drinking when she was going out with her friends, which is unusual from her, but it was an impulsive behavior. Also, the impulsivity when she took the tablets, for example. So she is showing impulsive behavior. There is also recurrent suicidal behavior, self-manipulating behavior, affective instability, and that's why it's very easy to misdiagnose borderline personality with a mood disorder like depression, because their mood is actually very reactive. And they can have also inappropriate, intense anger. They can feel very angry, and they can they cannot control the anger or contain it. So what's our role? We do not diagnose personality disorders. We can suspect them. So our role is to refer to the psychiatrist to confirm the diagnosis. We can tell the patient that we're suspecting a personality disorder. That's totally fine. But we may not confirm the diagnosis until it is diagnosed by a psychiatrist. We need to recognize self-harm if it's there. And patients with personality disorders, they can come back to you even if they follow up in the hospital. And it's up to you whether you're going to see them again or not. But it could be helpful to reassess their problem again, see if they actually need help, see if they're self-harming or not, and refer if needed. Okay? Now we'll move quickly to personality disorders. I'm not sure if I have enough time, but I'll be very quick. In general, personality disorders are divided into 3 clusters: cluster A, cluster B, and cluster C. There is it's not a mnemonic, a way to describe them that makes it easier, even though the terminology is a little bit judgmental and we shouldn't use it in the clinical sense. But usually they say cluster A is the weird, cluster B is the wild, and cluster C is the worried. So weird, wild, and worried. Weird because the description of this personality disorder is that it's odd and eccentric. And we'll talk quickly about them. Wild because cluster B are very dramatic, very theatrical, very emotional. فيها narcissistic personality, borderline, antisocial. C, anxious and fearful, that's why worried. So weird, wild, and worried. And if you remember, I told you previously, look at the name of the condition. So paranoid personality, schizoid, and schizotypal. Paranoid, they have paranoid suspiciousness, paranoia, pervasive distrust. Allahu Akbar. And usually it begins early in life. And they have this paranoia with everyone. ممكن يقول لك انه هو يشك بالاخرين، يشك يقول لك انه هو يقرا افكارهم. They can bear grudges as well. And the main theme is paranoia. Schizoid, what can remind you of schizoid is avoid. Avoid and schizoid, they end with the same. So there is a pervasive detachment from social relationships. يحبون يقعدون بروحهم. And it's not just إنه ما يحب إن متضايق من هالشيء, they're actually okay with it. They don't like to be with people. They don't like to have close relationships. They don't have interest in close relationships. They don't have interest in sex sometimes. And they prefer solitude. They have restricted emotional expression. Schizotypal, what's special about it is they have a lot of odd behaviors and eccentric behaviors. So مثلا يلبسون ملابس وايد غريبة, they have very odd beliefs. They have magical thinking. مثلا يقول لك والله أنا أقرأ أفكار الشخص اللي قدامي, أنا أشوف الأورا مالت الشخص وأقدر أحكم عليه من الأورا مالته مثلا. تسمعون هالأشياء ساعات. مو معناته أي أحد يقول هالشيء معناته عنده schizotypal personality, بس يعني في ناس إذا if they actually believe in it, maybe it could be, I don't know. بس يعني they have people with schizotypal personality, they have magical thinking. That's what's special about it. So each condition has something special about it. We talked about borderline. Now cluster B is the wild, is the dramatic, is the emotional. So cluster B usually can be misdiagnosed with anxiety, with depression, with mood disorders, for example. Antisocial, as the name suggests, it's antisocial. So there is violence in it. There is deceitfulness in it. There is someone that's going against the people in his life. There is impulsivity, lack of remorse. ممكن مثلا ياخذ سيارة أخوه يدعم فيها ويقول مو أنا اللي دعمت مثلا. They don't take responsibility and they don't feel any guilt يعني about their behavior. There is disregard of safety. And what's special about antisocial is also there is high criminality in it. So a lot of the people who go to jail might have actually antisocial personality. Borderline we talked about. And what's good to mention is that specifically borderline and many other personality disorders can be treated with dialectical behavioral therapy. DBT is unfortunately not available. As far as I know, it's not available in بالحكومة. We have CBT. But DBT specifically can be very helpful for such patients. Histrionic personality, again, as the name suggests, histrionic has to do with emotions. There is excessive emotionality and attention seeking. They cannot bear not being the center of attention. They have to be the center of attention. And they're sometimes shallow and in terms of how they feel. They don't have emotional maturity. They have theatricality. مسرحيين شوية, drama يعني. This can be a way to describe a patient with histrionic personality, but it's good to know that patients with histrionic personality are very difficult to diagnose. They can be very easily missed, even like not by us, because it's very difficult for us to recognize it, but even for psychiatrists to diagnose a histrionic personality is not easy. Then we have the very well-known the narcissistic personality, and it has this grandiosity feeling, I'm superior to others, need for admiration, lack of empathy, and exploitation of others as well, and sense of entitlement. It's good to know that narcissistic and antisocial are more common in men. Borderline and histrionic are more common in women. And it has to do with how women and how men are in society. That's why it's more common in each gender. Then we have the cluster C, the worried. So it has to do with anxiety, all of them. So there's avoidant, and as the name suggests, it's avoidant. So there is social inhibition. There is feeling inadequacy, hypersensitivity to negative evaluation. They cannot take any criticism. They avoid interpersonal contact. They fear rejection. What's the difference between avoidant personality disorder and schizoid, اللي من ساعة تكلمنا عنها, اللي يحب يكون بروحه, they prefer solitude. In avoidant personality, they actually want to be with others. In avoidant personality, they want to be in a relationship with others, but they have fears of rejection and feelings of I'm not good enough, I'm inadequate, I'm not good enough for you, feelings like that. But they actually want to be in a relationship. in comparison to schizoid, where they actually prefer to be alone. Dependent personality disorders, again, as the name suggests, it's dependent. Then they have to be dependent on someone. They have a lot of difficulty making decisions. They're afraid of abandonment. أي شيء بسويه لازم أدق على فلان أو فلانة، ها إيش رايك؟ أسوي كذي ولا لا؟ Even with minor decisions, they are dependent on other people. Obsessive compulsive personality, again, as the name suggests, there is a preoccupation with orderliness, perfectionism, control of the environment, rigid rules, hoarding sometimes, reluctance to delegate. لازم أنا أسوي كل شيء. And the difference between obsessive compulsive personality and obsessive compulsive disorder, in obsessive compulsive personality, there isn't the obsessions and the compulsions in the sense that we have in obsessive compulsive disorder. OCD has this aspect of compulsions and obsessions. That's not available here. That's not seen in obsessive compulsive personality, but they have this perfectionism, this need to control. Yes, and it's also good to know that all personality disorders require therapy. And medications can be used, but therapy is more important. I have questions here. You can look at them later. Maybe because of the time restriction, I need to talk about this because I'm very passionate about it, and I think this approach should be adopted by us family medicine doctors, which is the biopsychosocial approach, the holistic approach. It's very important to understand that us as human beings are not separate, like our minds are not separated from our bodies. Our relationships are not separated from our biology and psychology. Our life experiences also are not separated from our psychology and biology. We are an interconnected being. So it's good to see that, even though conventional medicine kind of dismissed this idea of interconnectedness, but we are actually coming back to it. And I have evidence. I can prove it because people who exercise, for example, according to multiple meta-analyses, not one, the multiple meta-analyses suggest that moderate intensity exercise can be as effective as SSRIs in treating moderate depression and anxiety. And in one meta-analysis, it even suggested that exercise should be prescribed as a treatment for depression. Sleep is very important. If you're not sleeping well, your mood's not going to be as good as it's supposed to be. So we need to assess sleep with any case of a psychiatric disorder, and we need to make sure that we advise them on sleeping well because it's a huge part of our lives. Mental processing, our neurology needs sleep. Caffeine intake also for patients with anxiety. If we reduce the caffeine intake, we will notice that the anxiety itself can be reduced as well. And there is a study in which they tested the Mediterranean diet in patients with depression. It's called SMILES trial. And it's not the only trial, many other trials. Maybe the Mediterranean diet, because of its high omega-3 content and fiber content, it might have a biological effect on patients with depression, in which it reduces actually symptoms of depression. So what is our role as family medicine doctors? What do we need to do as family medicine doctors? We need to understand that people living with mental illness suffer from isolation. They suffer from loneliness. They put a lot of boundaries around them. They don't want to talk about how they feel. They feel very vulnerable. And they adapt to this vulnerability by actually isolating, by shutting down, by building walls. Why do they do that? Because maybe when they actually were vulnerable with someone, بالمجتمع مثلا لما الواحد يقول أنا أشعر بكذا وكذا وكذا، ما فيك إلا العافية، اذكر الله، يمكن أنت يعني تبدي الأحكام عادي، يمكن أنت مثلا ما تصلي أو ما يعني ممكن يصير في أحكام. أو ممكن تكون عين مثلا، عين ما صلت على النبي. ف people end up isolating. And it's still very stigmatizing to actually seek mental health services in Kuwait and in our region and worldwide as well. So it is important for us to hold the patient in a safe environment, in a compassionate and non-judgmental environment. This is our responsibility because we actually provide this space. And I cannot also, we are human beings. Sometimes we are judgmental. Sometimes we are not in the mood. So that's totally normal. But we need to understand that it is our responsibility to provide this space. So we also need to take care of our own mental health. We need to take care that we avoid burnout, for example, and we practice certain practices that help us be present and calm and collected, and to help us be more connected with ourselves, basically. I think this is very important. It can be easily dismissed, but it is very important. Towards the end, I mentioned a few psychiatric medications that I think we need to know, specifically the ones, these information here, they like to ask about them in MCQs, like which one is used in breastfeeding, which SSRI is used in breastfeeding, for example, which one is avoided in pregnancy. These are the different kind of medications and their side effects. These are some of the references I used, and thank you very much for giving me this space to actually talk about this. And if you have any questions, I'll be very happy to answer.
Thank you, Dr. Saad, for this excellent session. Doctor, we have one question.
Okay.
You don't mind to answer on it. Why is it challenging to detect mental health issues in primary care setting? And what are your suggestions for minimizing this challenge?
So the reason why it's difficult to detect them, because sometimes when we are sitting in the primary care setting in a general clinic, for example, it's very crowded. We do not give the patient enough time and space, especially if in certain areas, like certain areas have, when you sit, you have like 20 or 15 patients waiting. It's difficult to actually pause and sit with the patient and neglect the 15 patients waiting outside. So this is very challenging to the doctors. And also the environment itself can be noisy. It can lack privacy. It can lack, and when you lack this privacy, the patient will not feel safe enough to actually talk about how they feel. But it's also our responsibility to screen if we suspect psychiatric conditions. We should ask the patient. But I think that's the main reason why it can be challenging, because otherwise it's easy actually to spot if the patient is going through a psychiatric disorder. And us as family medicine doctors, we also take care of the nonverbal cues, not just what the patient tells us, but their body language and their eye contact. And we look at things that can also give us cues about the patient's internal environment. So it's not difficult in itself to diagnose or to detect psychiatric disorders, but the environment is not the best for us to do that. That's what I think, at least.
Thank you, Dr. Saad. يعطيك ألف عافية.
الله يعافيكم. شكرا لكم. ألف شكر.